Lakeland Currents, your public affairs program for North Central Minnesota. Production funding for Lakeland Currents is made possible by Bemidji Regional Airport, serving the region with daily flights to Minneapolis-St. Paul International Airport. More information available at bemidjiairport.org. Closed captioning for Lakeland Currents is sponsored by Nisswa Tax Service, tax preparation for businesses and individuals. Online at nisswatax.com.
Hello again, friends. I'm Jason Edens, your host of Lakeland Currents. Thanks for joining the conversation, and thanks for your ongoing support of Lakeland Public TV. We are fortunate here in our viewing area to be home to world-class healthcare. From Bemidji to Brainerd and beyond, we are served by a wide variety of healthcare providers, including Sanford Health, Indian Health Service, Essentia Health, Lakewood Health, and the Cuyuna Range Medical Center right here in Crosby, Minnesota. And it's the Cuyuna Range Medical Center that has recently welcomed a new spine surgeon, and I'd like to do the same. Dr. Stockman, welcome to the program, and thanks so much for making time.
Jay, thank you. I'm excited to be here.
So, Dr. Stockman, first and foremost, I understand that you coming to Cuyuna Range is a bit of a homecoming, isn't it?
Yeah, so I graduated from high school here in 2005, and I've actually now been away for longer than I grew up here, even though I was here since the age of 4. So it's exciting to be back for me for sure.
Nice. Well, I read in the press release that welcomed you that your spine care practice is holistic. And I'm curious if you could tell us a little bit more about that. How is it holistic? And what's unique about the service that you're providing at CRMC?
It's a great question, Jay. I think we have a very comprehensive spine program because we have medical spine experts. We work in conjunction with interventional pain. And so we do injections and we share a clinic space with them. And then we also bring surgical spine, which, as you know, is new to the Brainerd Lakes area. And so that gives us the ability to dialogue on patients, to try injections, to really figure out what the problem that patient is having before we would recommend any sort of surgical intervention.
Well, that's really interesting. I was going to ask you about that. I was going to ask whether or not spinal surgery is a last resort, or do you typically encourage other interventions or other treatments prior to surgery? Can you help us understand that a little bit?
Yeah, so that depends. Most of what we do here is degenerative spine care. And so then that is a last resort, because if you have a patient that can benefit from physical therapy, maybe manipulation, or an injection, that may be enough to buy them time or to overcome their problem. And so certainly we want to exhaust all those options before we would recommend something more invasive like surgery. That said, there's also spinal conditions that need urgent intervention, where it would be a disservice to the patient if you didn't offer them surgery to address their problem. So it does vary a lot, but we see and take care of all of it, I would say.
I want to make sure that we're all understanding some of the nomenclature that you're using. So when you say manipulation, what exactly do you mean by that?
I think there's room for lots of treatment of spine care, whether that's chiropractics, acupuncture, traditional physical therapy. There's good studies that say that even yoga or kind of other forms of exercise are really helpful for maintaining spine care and for treating low back pain, which is one of the most common diagnoses that we see and is the number one cause of disability for people under the age of 45. So I think there are lots of different treatment options, not just one.
So you also mentioned degenerative. Can you help us understand what's an example of a degenerative condition?
Yeah, so I think for patients, this is easy to understand with like hips and knees, where you have bone-on-bone arthritis in your knee and you need a knee replacement or a hip replacement. And the same thing happens in the spine. You do wear out, you do get bone spurs. And so that's what degenerative disc disease or an aging spine can do. And then it causes pressure on the nerves. Spinal stenosis is a common thing that we see as you age. The disc spaces collapse and they balloon out. And then you have bone spurs also that form in the back and the facet joints. And all that contributes to narrowing around the spinal canal and spine-related pain.
It's probably safe to assume that you're not a one-man service provider. So can you tell us a little bit about the care team that helps make your work possible?
Yeah, so spine, like you had mentioned, is new to the Brainerd Lakes area. And so we brought on an RN who had been working in the cities in spine clinically for 2 years, taking care of spine patients, and then also 2 years building a spine practice down this in the cities. And so she has been here working, training our staff in the clinic, in the OR, and then on the floor, so that we're ready to take care of spine patients. And then we also have a PA that's joining, and Kaya, the nurse, is in nurse practitioner school, and she'll be wrapping that up in the next year or so.
So you have a dedicated PA, and by that I'm assuming you mean physician's assistant.
That's correct. Yes.
Okay.
Yep. Kind of right hand man to assist in the OR with retraction, protecting the neural elements, being able to perform surgery safely.
So why would someone come to Crosby in order to receive some of these treatments that you're referencing rather than, say, Rochester?
Yeah, good question. Why would you go somewhere else when you have excellent spine care here close to home, is what I would say. I think some of the patients that come to us as a small hospital, if we're not set up to take care of that patient because of the magnitude of the surgery they would need, if we can't do it safely, we're connected with several spine surgeons in the cities very closely. And so we will refer those patients out if we can't safely take care of patients. But I did my training at Ortho Carolina, which is a very well-respected spine fellowship program, highly competitive. I had job offers throughout the country, but I wanted to come back here where I grew up into a community that I love and bring a service that is really, really needed here.
Well, I was going to ask you a little bit about your motivations. I'm not surprised to hear that you had opportunities elsewhere in the country. What exactly are the limitations of your spine care clinic? What would actually necessitate you to refer someone elsewhere?
The main thing would be the magnitude of the surgery. If it was going to be a deformity surgery, for example, in a more elderly, more sickly patient, to be able to have the resources on site and available for the ICU cares that can sometimes be needed after those large surgeries, or to deal with complications. I think the same thing if you have that would probably be the main thing. We're working on bringing in access surgeons so that we can also provide anterior lumbar interbody fusions, because you have to be able to do, if you offer something, you want to be able to do it safely. You have to have the patient in mind, their best interest in mind. And so that would be when we would refer patients out.
Is it common after a spinal intervention or procedure for someone to spend time in the ICU?
It's not common, but again, it depends on the type of surgery. Some spinal surgeries are lots of blood loss and all day, and those type of surgeries, just the fluid shifts, the things that happen afterwards, the risk of heart attack or stroke, those are all elevated more. And so in those settings, yes, and that's not the type of surgery that we're starting out with here, I would say.
Sure. You know, you've just brought something else up that I was going to explore a little bit with you. When reading your website, I read a lot about the benefits of some of the procedures that you provide at CRMC. And on your website, you allude to risks without listing them. So I was curious if you can tell us, what are some of the risks of some of the procedures that you're providing at CRMC, such as an ACDF, for example? What's that? Anterior cervical discectomy and fusion? Yep,
discectomy and fusion. So those risks are standard across, I mean, any surgical specialty. You have risk of infection, risk of damage to neural elements, and then the risk that unless we know what it is we're treating, and we offer surgery, but we don't operate on the right level or do the right surgery for you, that you don't actually get better. And I think spine surgery has a bad reputation for that, in that you have patients who undergo spine surgery and you hear that they're worse off than they were before. And part of that is maybe some the inherent risk of any surgery, but it's also making sure that you understand what the problem is, what the pathology is that's causing that patient pain, so that you can address it adequately, but in as minimally a way as possible.
So in order to minimize the intervention or the extent of the surgery, you know, just how invasive are some of these procedures? relative to say 10 years ago, for example? I'm assuming they're less invasive, but maybe that's not correct.
It's interesting. It really has changed a lot, and it depends on what the pathology is, whether you can approach it just from the front. You mentioned the ACDF. That's about an 1.5 inch incision. Patients, usually their arm pain is improved immediately after the surgery. And we keep them overnight, just to keep an eye on their breathing to make sure that they don't have any issues. And they go home the next day, but they're up and walking right away. And that's true for almost all spine surgeries, is unless you come in with a traumatic injury, some sort of high-speed motor vehicle accident or something, it's really being up and moving right away. So things that have changed are post-op day 0, we have patients getting up and moving around, and that's important for preventing pneumonias, urinary tract infections, things like that, blood clots. In terms of kind of invasiveness, how has that changed? I do a lot of lateral interbody procedures where you come in from the side through a small incision and take out that disc space and replace it with a spacer. And that allows for staying out of the canal, decreases your risk of a dural tear or a spinal fluid leak. And it's also less invasive. And so you have patients who are able to mobilize more quickly, post-op day 0, post-op day 1, and discharged from the hospital. And no one wants to be spending more time in a hospital with COVID.
Indeed. And I do want to visit about COVID a little bit in a moment, but you just mentioned an automobile accident. And one of the questions I wanted to ask you was, do you end up being a part of any emergency procedures as a spine care specialist? Do you find yourself in the ER?
Yeah, absolutely. I see people that come into the ER. I see patients that come in with acute problems. You could have a large disc herniation, for example, and develop cauda equina, where you lose control of bowel or bladder function, and that's dealt with on an urgent, emergent basis. Alternatively, you could have, same scenario, a disc herniation where you end up with a foot drop. And that's something where then it's great to have a patient come in so that we can actually have a discussion about the risks, benefits, how long do we watch this, when do we intervene, what's the best window of opportunity so that they maximize their function, their strength, but don't necessarily undergo a surgery if it's not necessary, if it's going to get better on its own.
We have already talked about the fact that you're one of the few people providing any service of this nature in greater Minnesota, or certainly north of the Twin Cities in our region. But I've noticed that there are orthopedic surgeons in our community. So can you help us understand what's the difference between an orthopedic surgeon and a neurosurgeon? Is that the correct term for you, sir?
Yeah. So the difference between an orthopedic surgeon and a neurosurgeon is the training. Orthopedic spine focuses on the subaxial spine, meaning that we don't do, if you come in with a intracranial hemorrhage or something in the skull or an aneurysm, that's not stuff that we deal with. But we focus on the bones, decompression, the neural elements, basically from the base of the skull down to the pelvis. And so our training is very much more focused on bones. We're bone surgeons. I did 5 years in orthopedic residency, treating tumors, hip fractures, ankle fractures, spine pathology, both in pediatrics and adults, but then went on to subspecialize in spine care.
Now, you mentioned a moment ago inserting a spacer. Now, I'm assuming that's between vertebrae, correct?
Correct,
the case
yep.
of the disc that has failed?
Correct.
So what exactly is that made of? I'm just curious what it is that we're inserting in between the discs.
And this is actually a really interesting area. There's a lot of research going into it. Usually it's either plastic type material called PEEK, or often what I'm using is 3D printed titanium. And that's printed in a way that bone is able to grow onto it, through it, to form a better interface.
Interesting. Now, with lower back pain and a variety of back issues, I'm sure there's some palliative care that's involved in your treatments. And of course, nationally, we have an opioid addiction epidemic. And I'm curious, what is your responsibility in preventing addiction?
It's something we take very seriously. And before anyone signs up for surgery, we actually discuss this with them and have them sign something saying that they understand that we'll treat their pain. We're going to treat their pain surgically, we'll also treat their post-surgical pain, which is with multimodality measures such as Tylenol, NSAIDs, gabapentin, sometimes steroids, and opiates is a component of that. But we treat their pain with pain medications only as long as it's surgically indicated in that post-operative period. So there's a lot of education that goes on to that.
So it sounds like you're talking about client education. I'm curious, as you were going through your rigorous training, was that a part of your education? Did you learn?
This is something that we're all becoming more educated on as physicians. During medical school, it was just starting to come to the front. When I was doing my orthopedic residency training, we routinely would send patients home after an orthopedic procedure with 4 times the amount of medication than we do now. And that's true across the country, and it's something that we've made huge advances in, especially just in the last 5 years.
I'm sure that the Cuyuna Range Medical Center is very committed to transparency. And so I was wondering if you could just tell us a little bit about the fee schedule. And obviously this depends on the individual. It depends on the extent of the procedure that you're providing. But can you speak to how much it costs to have some of these procedures?
I can't speak directly to it, but we do take all insurance. I'm in the process of getting credentialed with just the last few. And so, a standard consultation to see me through insurance, and then that gets covered on the insurance side of things. Certainly as a physician, as a surgeon, it's important for me to balance where is it worth spending extra money in the OR so that the patient has a successful outcome, and where is it important to be conscientious of the resources that we have and kind of balancing that. So that's what I would say to that.
And how, you of course mentioned COVID-19 a moment ago. How would you describe, how has your practice changed as a result of COVID? Have there been any lessons learned or even silver linings potentially?
For me, I went into medicine because I loved taking care of people. I loved trying to understand what their problem was and how we could fix it, how we could make it better. And so I think certainly one of the challenges is in connecting with the patients and in connecting with the staff to do that in a human way when you can't see the face in front of you, when you can't see their expression of excitement because they feel so much better, or the hurt in their face because they're really struggling. And so that's been challenging. In terms of silver linings, I guess maybe it's easier to do this interview and I'm able to do it from my office instead of coming in and sitting with you, but truthfully, I'd rather be there in person.
Well, I was wondering if you could share some success stories. Tell us about someone whose life has been dramatically changed as a result of the service that you're now providing in our region.
So for me, seeing the post-op patients walk into your clinic and say, "Doc, I feel so much better. My leg pain is gone. My back is sore because I just had surgery, but look, I'm standing up and my foot is stronger than it used to be." That's awesome. Or to have someone who is slowly decreasing the amount of distance that they can walk. So you have someone that's active, wants to be outdoors, wants to go for walks with their significant other, and they see that slowly being taken away from them, where they're walking a mile, now half mile, and now they're just looking for a chair. And this is a slow, gradual process that happens over the course of years, typically, as arthritis, disc collapse, all these things contribute, and it becomes more and more symptomatic. And yet, that's something that changes immediately because you go from a gradual, slow progression of tightening around the nerves to them being open again. And so even in the hospital, I love when you see patients walking around the halls and they say, "I can walk further now, post-op day 0, post-op day 1 without that pain than I could in the last 6 months or year." And then they come back at 2 weeks and they're still sore in their back because they're still recovering, but they're already doing more than they were before. I think that's super exciting.
So why is it that CRMC decided to add this service to its existing suite of services?
So we have an excellent team of orthopedic surgeons. One of the things that's unique about our program here at CRMC is we're all fellowship trained. And so just to broaden and be able to provide the care that people need in the community, and there was a hole, and that was spine pathology, spine care. And bringing on a spine surgeon, it's also allowed us to build up our non-operative spine care because we're seeing more and more patients with spine pathology. Some of it surgical, some of it not surgical. And so it builds kind of all the different ways in which we can take care of spine patients.
So one of the things I was really eager to ask you about is the next frontier, the new frontier for neurosurgeons, neuroscience, spinal interventions.
Yeah.
If we were to have this conversation, say, 30 years in the future, what procedures might we be talking about?
That's a great question. There's definitely been a lot of advancement in terms of procedures that are offered, that I offer, that are non-fusion procedures. And so that's an area where we have seen advancement, such as cervical disc arthroplasty. We had talked about ACDF, which is a fusion, but there's also ACDA, which is an arthroplasty. And in the appropriate patient, that shows really good results, equal durability, and maybe even some improvements in terms of not having breakdown above or below that level that's operated on. In terms of other advances, I think that lateral approach, being able to do procedures in a much more minimally invasive way when possible. Again, it's not always possible because you have to make sure that you're addressing the pathology, that you're actually taking care of the problem that the patient has. Because if you don't take care of the problem, it doesn't matter how small the surgery is or how big it is, that's a patient that's not happy. But if you can take care of their problem, relieve their pain, and address it in a durable and minimally invasive way when possible, that's a happy patient. In terms of advances in spine surgery in the next 10, 20 years, I'm excited to see what it is. And I think that most of us don't know what it will be, but we know that with medicine, with all the intelligent minds that are working on these problems, that we're pushing towards it. Certainly one of the things that we'll see is better patient-reported outcomes and an understanding of how patients are doing with spine surgery. That's something that we're a part of. The American Spine Registry, we're an early adopter of that to actually look at patient outcomes, need for reoperations, what are the infection rate, all these things that are true of surgery so that we can actually understand and benchmark ourselves and compare ourselves to other areas in the United States. The other thing that we're understanding more, and this with that long-term data, I think you need 10 years of data to really look at it, but when you put in that cage, like that 3D titanium printing cage that you had asked about,
Mm-hmm.
Where do you put that? How do you change the alignment of the spine and its relationship to the pelvis so that you have the most durable result possible? And there's been a lot of fascinating research done on that, and we understand so much more on that than we did just 10 years ago. So it is advancing a lot.
Do you think that it's possible that paralysis will be curable in the future and we can somehow reverse existing paralyses?
I think there's more potential in terms of kind of acute spinal cord injury and recovery. Paralysis is, that's a different thing because when you talk about paralysis and that having been something that's gone on for a long time, your muscles need to be firing in order to stay alive and work, and if not, they atrophy. And so I don't know exactly what the horizons are on that, but certainly in acute spinal cord injury, there's more opportunity.
What kind of cross-training do you do with your peers across the country? You've mentioned that you're an early adopter of a set of standards, if I understand you correctly. Mm-hmm. What type of continuing education is required in your craft, and what type of cross-training do you do with your peers?
So just like any physician, there's a CME that I maintain, and then especially for me being here at CRMC, it's super important for me to stay active in meetings and in discussion. And I think that's one of the benefits of coming from or working at a facility where you train residents, where you train fellows, is you stay on top of the most current research, the current standards. And so actually the LSRS, the Lumbar Research Spine Society, is meeting November 12th to the 15th, and I'm presenting an article there. Unfortunately, that's also going to be done remotely, and so I don't have the chance to interact with my senior mentors from fellowship, from residency, but so routine meetings and continued research and yeah.
So we only have just a brief amount of time left here, and I wanted to ask you one thing about your motivation. So I think you've already kind of alluded to this, Dr. Stockman, but I'm curious, why is it that you wanted to become a spine surgeon or a neuroscientist? How long have you had that aspiration? What motivates you each and every day?
So I did a lot of construction work growing up. I did 5 summers of construction work, roofing, building new houses, remodeling, and I loved the hard work and the hands-on aspect. And so then when I went into medicine, I realized that if I could do that kind of work for patients to make their lives better in a way similar to, how you're better if your roof doesn't leak, if it's reshingled. If I could do that with my hands, that I had a skill set that I could bring, that I love doing, that could help patients. And so I went into orthopedics with that mindset, and I love all of orthopedics. Joint replacement, pediatrics. I just loved fixing stuff. And then what I loved about spine, which kind of surprised me, was understanding the patient, that human relationship that you have in terms of figuring out where is their pain coming from, what exactly is it that's causing them pain, because it's one of the most complex areas of the whole person. And so how do you zone in on exactly where that pain is coming from and how do you make it better? And that was what I found so interesting about spine surgery.
Well, Dr. Stockman, I'm very grateful that you're providing this service in our region, and I'm very grateful for your time today. Thank you so much for making time.
Thank you, Jay. Appreciate it.
And thank all of you for joining me once again. I'm Jason Edens, your host of Lakeland Currents. Be kind and be well. We'll see you next week.